Welcome to the series where I review the 2025 AACE consensus statement on the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Today I will discuss the evidence supporting weight loss medication preferences, starting with cardiometabolic obesity-related complication-centric disease. I'll begin with prediabetes, metabolic syndrome, and diabetes prevention. For individuals with prediabetes or metabolic syndrome, semaglutide or tirzepatide are the preferred medications for preventing progression to overt diabetes. This preference is driven by the magnitude of weight loss achieved, as well as direct glucose-lowering effects through incretin physiology. In addition, these medications provide clinically meaningful cardiometabolic benefits, including improvements in lipid parameters, blood pressure, and inflammatory markers. Liraglutide and the combination of phentermine with topiramate are considered second-tier medications. They remain highly effective for diabetes prevention, although outcome data are less robust compared with semaglutide and tirzepatide. Orlistat is considered a third-tier medication in this setting. Transitioning now to type 2 diabetes. For individuals with type 2 diabetes and obesity, tirzepatide and semaglutide are first-tier medications. This ranking is based on the degree of weight loss achieved, the magnitude of hemoglobin A1C reduction to target, and low rates of hypoglycemia. Liraglutide and the combination of phentermine with topiramate are second-tier medications and remain effective treatment options. Orlistat and the combination of naltrexone with bupropion are considered third-tier medications. Moving next to cardiovascular risk. With respect to major adverse cardiovascular event prevention, semaglutide is the only obesity medication thus far that has been shown to reduce risk of major adverse cardiovascular events in a cardiovascular outcome trial involving secondary prevention in people with obesity and not diabetes. Tirzepatide may also be efficacious for cardioprotection based on post-hoc analyses of the SURMOUNT-1 extension trial, which showed reduced hazard ratios for MACE. Liraglutide, 1.8 milligrams per day, demonstrated cardioprotection in people with obesity and type 2 diabetes in the LEADER cardiovascular outcome trial. A morbidity and mortality outcome trial is ongoing for tirzepatide. Definitive data for cardioprotection are lacking for other medications. Shifting now to liver-related complications. This is based on clinical trial data demonstrating improvements in liver histology and fibrosis. It is also important to note that any weight loss intervention achieving 5 to 10% weight loss or greater will predictably reduce hepatic steatosis. Next, blood pressure lowering. For individuals with adiposity-based chronic disease complicated by hypertension, tirzepatide and semaglutide are preferred medications. Phentermine with topiramate extended release follows closely behind. This hierarchy is based on improvements in blood pressure observed in clinical trials. Liraglutide and orlistat are considered second-tier medications. Turning now to kidney disease. Semaglutide is the preferred medication for chronic kidney disease. Clinical trial data in people with type 2 diabetes demonstrate that a dose of 1 milligram weekly slows the rate of decline in estimated glomerular filtration rate and reduces renal outcomes. Liraglutide at 1.8 milligrams daily also demonstrated renal protection in a secondary analysis of the LEADER trial. A dedicated clinical trial assessing the renal effects of tirzepatide is currently ongoing. Post-hoc analyses from earlier trials in people with type 2 diabetes support the expectation of renal benefit. Finally, heart failure with preserved ejection fraction. Tirzepatide has been shown to improve symptoms, physical function, and heart failure outcomes, including reductions in urgent care visits and hospitalizations in individuals with heart failure with preserved ejection fraction. Semaglutide has also been shown to improve symptoms and physical function in this population. Moving now to biomechanical complications. Starting with osteoarthritis. Semaglutide is the preferred medication for individuals with obesity complicated by knee osteoarthritis based on clinical trial data. Weight loss greater than 5% has been shown to improve osteoarthritis symptoms. And finally, obstructive sleep apnea. Tirzepatide and phentermine with topiramate are preferred medications for the treatment of obstructive sleep apnea in people with adiposity-based chronic disease. Clinical trials demonstrate improvements in symptoms and reductions in the apnea-hypopnea index during polysomnography. Tirzepatide is now approved by the United States Food and Drug Administration for the treatment of moderate to severe obstructive sleep apnea in adults with obesity. I had to think about this a bit, but to close, think about obesity treatment by organ system, not the number on the scale. For sugars, for glucose, meaning prediabetes, diabetes prevention, and type 2 diabetes, the answer is consistent. Semaglutide and tirzepatide come first. They produce the greatest weight loss, the strongest A1C reduction, and minimal hypoglycemia. Liraglutide and phentermine with topiramate still work well, but they sit one step behind. For cardiovascular disease, semaglutide is the only obesity medication with proven MACE reduction in people with obesity without diabetes. Tirzepatide looks promising, but outcome data are still emerging. For the liver, remember this. Weight loss matters most, but among medications, semaglutide leads with improvement in liver histology and fibrosis. Any therapy achieving 5 to 10% weight loss will reduce hepatic steatosis. For BP, again, tirzepatide and semaglutide rise to the top, and phentermine with topiramate close behind. For the kidneys, semaglutide is preferred with evidence for slowing GFR decline and reducing renal outcomes. Tirzepatide is expected to follow with supportive post-hoc data and trials underway. For heart failure with preserved ejection fraction, tirzepatide stands out, improving symptoms, function, and hospitalizations. Semaglutide also improves symptoms and physical performance. Finally, for mechanical complications, think simply. Knee osteoarthritis, semaglutide. Obstructive sleep apnea, tirzepatide or phentermine with topiramate. With tirzepatide now FDA approved for moderate to severe OSA. If you remember one thing, remember this. The more powerful the weight loss and incretin effect, the broader the benefit across every organ system. In the newsletter, I have given a PDF, and if you look at it critically, you'll see the sugars, tirzepatide, semaglutide. Type 2 diabetes, tirzepatide, semaglutide. MACE prevention, semaglutide, liraglutide in type 2 diabetes. BP, tirzepatide, semaglutide with phentermine topiramate. CKD, semaglutide, tirzepatide. HFpEF, semaglutide, tirzepatide. MASH, tirzepatide, semaglutide. OA, semaglutide. OSA, tirzepatide with phentermine and topiramate. This was another bite-sized episode of Endo in a Bite. In the next few episodes, we will be working through the details of the AACE consensus statement, the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease, the 2025 update. Remember to visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam prep. Let's get through this document one bite at a time.